Good morning, everybody. As we let people out of the waiting room, we will just give it 1 second to make sure that we have a crowd here with us, and then we will get started in just a few seconds. Okay, I'm seeing our numbers start to climb, so I am going to go ahead and get started. My name is Megan Landry, and I am the Associate Director of Cancer Center Partnerships for the American Cancer Society. It is really my pleasure to welcome you all to our event today. We ask that if you have called in from a phone, that you please enter your name and organization in the Q&A so we have a record of your attendance. All lines will be muted during this program, and we ask that all questions be entered into the Q&A tab on your screen. We will be taking questions during our panel discussion and at the end as time permits. If we do not have time to answer your question during the Q&A, we will work with the presenters to have your question answered post-event. We're so glad you're with us today. Please answer our first poll question that will pop up on the screen in just a second. We would love to know what sector you represent. We'll have several polls throughout this program and appreciate your participation. Okay. So before we begin our program, we wanted to recognize and thank our sponsor. Without the generous support of The Ohio State University, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions and the Michigan Cancer Prevention Task Force for their continued support. Here is our agenda for today. We will begin with our welcome speaker, Ghada Azizs. Then we'll introduce our keynote for this morning, Dr. Samilia Obenjesi. Next will be a panel discussion around breast cancer and health equity. This will be followed by brief videos and case studies. The AAFP has reviewed Health Equity and Cancer Care virtual series breast cancer webinar and deemed it acceptable for up to 2 enduring materials self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after the presentation and that this event is being recorded. Now it's time for our second poll. How confident are you with your knowledge of breast cancer screening guidelines? I'm going to give everybody a second to vote before we move on. Okay. All right. Thank you for participating in our polls. It helps make this a little bit more interactive. It is now my pleasure to introduce Ghada Azizs. We have been longtime partners with Ghada, and we are so happy she's here with us this morning. Ghada Azizs is originally from the Middle East and has worked with Access for 21 years as a community health worker and educator to prevent breast, cervical, and colorectal cancer among the Middle Eastern, North African community and beyond. Ghada has shared, as a breast cancer survivor for 10 years, I want to give back to the Arab American community by increasing knowledge, awareness, and screening rates. Ghada, I will turn it over to you to share your story.
Good morning, everyone. I'm really so glad I'm with you guys. I'm sharing my story with you. My name is Ghada Azizs. I am a breast cancer survivor. For about 14 years ago, I was 40 7 years when I start with breast cancer. Before I work in Access, I was living in West Virginia state, and I was looking for mammogram, doing mammogram when I was starting. I was 31 years old, I wasn't have any health insurance. And because because I have a strong family history of breast cancer, my mother and her 3 sisters diagnosed with breast cancer, and just past July 10th, my last aunt, she passed away. She was surviving for 20 years, surviving with the breast cancer. So after that, I moved to Michigan, and I work with Access as an outreach and health educator with the MENA community. And I continue doing mammogram screen for mammogram. In 2009, I found doing my regular mammogram, and they told me there is a suspicious lump. I needed to come back within 6 months. In December 2009, after 6 months, they told me they found small cells of cancer, and I have to do a lumpectomy and a radiation, but really I was refusing to do a lumpectomy. I asked for mastectomy because I told them my mother, she have a history of breast cancer, and my mother at that time, the cancer cells is go back to the second breast, and I insist for mastectomy, but the doctor said, no, it's a small cells. Lumpectomy is fine with you. So I did through the at that time, it was back in 2009. The technique, it was the radiation is for 5 days. At that time, I haven't have enough time. I have to go back to work. I don't have enough time for the PTO. So it was, I have to go 7 o'clock in the morning for the first session, go back to work, and I have to go back again to the hospital, do the second session for the radiations, 3 o'clock, and go back to home just to forget to rest, for the resting. So I did that for 5 days, and I get rest in the weekend. After that, the radiation I get is as uncomfortable, and I get a little bit burned. I go with my life. I start normal, and I get my lifestyle, and I was healthy. Go back with my normal life. I lost weight. I was so happy with my kids, traveled. But this is my first part with my story. The second part with my story, actually, back with after 3 years in 2012, I find another small cyst. It's about 1 centimeter in the same breast, which is my left breast. Again, I freaked out again. And this is, I find out with my self-breast examination. So I back to the doctor, and I explained that. He told me it's from the radiation I did, but I did beg him to do a double mastectomy. So, and he said, okay, this is your decision. So I decided to do double mastectomy and construction. But when I did this construction, really, I go through a very hard time with the construction. I did infection with my right breast, with the breast. I didn't have the cancer in it. So I was suffering for really 8 weeks recovery, and really I was very in pain and it's uncomfortable, but with my faith really and my support my family, I got through it. Thanks God, I'm now okay, surviving for about 14 years, go back to my normal life. So this is the reason really I continue to educate my community. Really the detection from the first detection from the breast cancer is very important, because, you know, as most of my clients, when they came to me, they came the latest stages. I feel the community need a lot of educated from how they do breast self-examination, because they feel shame to touch themselves. They don't know how they reach to their, even they don't reach to their family and talk about what's cancers. They call it the other disease. So this is my mission really. This is my mission to reach to this community, to speak about it loudly, and to give the message to them to protect from this disease. Thank you for listening to my story. If anybody have a question to me, I'm glad to answer.
Thank you so much, Gada. And Gada will be sticking around for our panel, so you can also ask her some questions that she can answer during the panel discussion. But Gada, I just want to say thank you for sharing your story and your passion for serving those in your community. It's really inspiring, and I have learned so much from you over the years. So I'm looking forward to having you join our panel in a little bit. Thank you so much.
Yeah.
So please join me in welcoming our keynote speaker, Dr. Smila Obenjesi. Dr. Smila Obenjesi is a fellowship-trained breast surgical oncologist and associate professor of surgery at The Ohio State University within the Division of Surgical Oncology. Her practice is focused on surgery for breast cancer and benign breast diseases. She obtained her BS in biology with the highest distinction and departmental honors from Indiana University, Bloomington, and her MD from the University of Michigan Medical School. She completed her general surgery residency at the Cleveland Clinic and Society of Surgical Oncology accredited Breast Surgical Oncology Fellowship at Duke University. Due to her interest in health services research, after finishing her residency, she completed a master's in public health at the Harvard T.H. Chan School of Public Health. As a health disparities and health equity researcher, the overarching goal of her work is to understand how ancestry, social determinants of health, behavior, and stress interact to influence cancer initiation, progression, and mortality. I will turn it over to you, and I believe you have your slides.
Sorry, I couldn't find the unmute button, so I had to stop sharing my screen.
No problem.
So thank you very much for the opportunity to talk to you today. As it was mentioned, I'm a breast surgical oncologist here at Ohio State. The title of this talk is Internalization of Adverse Social Determinants of Health in Breast Cancer. I don't have any financial disclosures that are pertinent to this talk. So the objectives of this talk, at the end of the talk, the participants should be able to define social determinants of health. They should be able to explain ecosocial theory. They should be able to discuss the implications of allostatic load on cancer outcomes and also understand the effects of socio-environmental factors on gene expression. So let's start by defining social determinants of health. Social determinants of health essentially describe our everyday living and working conditions, and these are strongly influenced by governmental policy and also sociocultural values. Now, in this particular slide, we look at the social determinants of health of occupation. And this study is called the Whitehall study. It's the first of two studies, I believe. It was a study of British civil servants. It accrued about 17,000 men from 1967 to 1969. And the goal of this study was to understand the relationship between grade, employment grade, so individuals who had professions that are more desirable had a higher grade, and those who had professions that were considered less desirable had a lower grade. So this study looked at the relationship between employment grade and mortality or death. And what they found were that individuals who had better grade jobs, so administrators and also professionals and executives, over their life course had a lower mortality than individuals who had jobs that were considered lower grades, like clerical work, and in the other category that was comprised of messengers and unskilled laborers. So what this slide shows us is that occupation is a significant social determinant of health and has implications for mortality. Now, in this slide, we see a different social determinant of health, which is neighborhood. And so this slide is based on neighborhoods in the United States, and it compares individuals who live in neighborhoods with the highest socioeconomic status, and that's the dark blue, to individuals who live in neighborhoods with the lowest socioeconomic status. And what you see is the same thing that we saw with the slide on occupation, is that individuals who live in communities with low socioeconomic status have a higher overall mortality than individuals who live in neighborhoods with a low socioeconomic status have a worse mortality than those who live in neighborhoods with a high socioeconomic status. And this has been a consistent finding essentially across time. And actually, if you look at these graphs, what you see is over time, that disparity or inequity has been widening. And then the most recent example of this is the COVID-19 pandemic. So if you look at the map in the left upper corner, this is a map looking at the distribution of the social vulnerability index. The social vulnerability index describes the community's resource readiness to deal with a natural or man-made disaster. And communities in the darker blue are those that are resource poor. Communities in the lighter blue are communities that are resource rich. And if you overlap the incidence of COVID and the mortality from COVID onto the overall SVI map, what you see is what we saw with neighborhood socioeconomic status and also what we saw with occupation, is that individuals who live in neighborhoods that are resource poor had a higher incidence of the COVID disease or the COVID virus, and also had a much worse mortality from COVID. And so what the last three slides have shown is that across time, the Whitehall study was in the 60s, and then the last two studies have been over the 80s to the early 2021, is you see that consistently individuals who live in communities or who are resource poor tend to have higher incidences of disease, and over their life course tend to have a much higher mortality than individuals who are resource rich. And so what this really conveys to us is that social determinants of health have significant implications for our overall health. And this slide does a good job of illustrating that. So what this slide shows is that our genetic predisposition, which is what we are born with, only comprises about 30% of our overall health. And the majority of our health is actually is driven by our social determinants of health, which include things like access to healthcare, our social circumstance, behavioral patterns, and also environmental exposures. And it's important to recognize that behavioral patterns are largely also driven by social circumstance. The key takeaway from this slide is that social determinants of health have significant implications for our overall health. So now that we've defined social determinants of health and we've illustrated how they can affect health and also overall mortality, let's pivot to focus specifically on patients with a diagnosis of breast cancer. So in breast cancer, we see the same thing in that individuals who face adverse social determinants of health tend to have poorer outcomes than those who are much more privileged. And so in this first column, what we see is that individuals who live in neighborhoods with a low socioeconomic status are more likely to present with aggressive types of breast cancer, are more likely to present with advanced stages of breast cancer, and also have a worse mortality from breast cancer than individuals who live in neighborhoods with a high socioeconomic status. Studies have also shown that women who report social isolation are more likely to have progression of their disease than individuals who report having more social support. And lastly, what this particular column shows is that individuals who file for bankruptcy, which is an extreme form of financial hardship secondary to medical costs, are more likely to die from their disease than individuals who don't file for bankruptcy. So what this slide illustrates is that, once again, people's living and working conditions have implications across the cancer continuum, from stage of diagnosis to treatment and also to mortality from disease. So the next question that we ask in our research group here at OSU is, what is the mechanistic pathway between exposure to adverse social determinants of health and then the initiation of cancer, the progression of cancer, and also metastases of cancer? The question really is, how does the world that we live in and how we experience this world, how does it result in cancer progression? And also, how does it result in mortality from cancer? And to really think about this, we have to understand some underlying conceptual or theoretical frameworks that helped inform our conceptual framework. So the first theoretical framework is one called ecosocial theory, and it was developed by Dr. Krieger at Harvard University. And this theory has 4 components. The first is embodiment, and embodiment describes the relationship between the body and the environment, right? So it's the relationship between the body and place. And embodiment really is looking at how we internalize the environment that we live in. And the way that we internalize this environment is through embodiment pathways. So embodiment pathways include things like environmental exposures, they include things like social exposures and also biological exposures. So these are the pathways through which we view our environment and then we take our environment into our person. This theoretical framework also argues that who gets disease, when they get disease, and how often they get disease are largely driven by social determinants of health. So in this particular column, it talks about exposure, resistance, and susceptibility, and it argues that disease exposure, resistance, and susceptibility are driven by structural and intermediary determinants of health. So structural determinants of health describe governmental policy and sociocultural norms and values, whereas intermediary determinants of health describe living and working conditions, healthcare access, psychosocial support, and also biological factors like sex. So what this is arguing is that who gets disease, how often they get disease, and also who is at risk of getting disease are largely driven by social determinants of health, either at the governmental level or based on individual living and working conditions. The fourth component of this theory is the acknowledgement that the majority or the distribution of disease within populations are largely driven by structural determinants of health. And structural determinants of health are governmental policy. So a good example of that is the Indian Appropriation Act, where the United States government placed American Indians on reservation. This policy had significant implications for this population in that it changed their lifestyle, but also it changed the incidence and also the exposure to disease. And this particular governmental policy has had implications for increased premature death among this population, and also a higher incidence of chronic illnesses such as diabetes. And so the underpinning of ecosocial theory is that governmental policy and sociocultural values and norms can have significant implications for disease distribution. The next theoretical framework that underlines our conceptual framework is the weathering hypothesis. And as most of you most likely know, Black women in this country are more likely to have chronic illnesses and also have a higher mortality than their white counterparts. And this hypothesis argues that the reason for this disparity are persistent socioeconomic, political, and cultural marginalization that Black women face. So increased comorbidities, shorter life expectancy, and higher maternal mortality rates are significantly influenced by the adverse social environmental pressures that African American women face in this society. The third concept or framework is a qualitative framework by Professor Crenshaw, and this is the idea of intersectionality. So intersectionality is the idea that membership in multiple social categories, and social categories are defined as things such as religion, race, gender, class, ability, sexual orientation, and age, that membership in each of these social categories are linked to systems of power and inequality. And essentially, the more marginalized social identities that someone has, the less access to power they have, and their interactions with power are inherently different than individuals within different social categories who may have more access to resources and also may have more privilege. And so what these three conceptual frameworks allow us to do is to better understand the implications of our social environment on our overall health. So here at OSU, our conceptual framework is that social determinants of health, so things like social isolation, work-related stress, and financial instability, actually work through the stress pathway. And the stress pathway works with the hypothalamic pituitary adrenal axis and the sympathetic adrenal medullary pathway. And so through this stress pathway, this can have implications at the physiologic level, and it can also have implications at the molecular level. So now we're going to pivot to focus on the physiologic implications of exposure to adverse social determinants of health. And to do that, we're going to talk about the concept of allostasis and allostatic load. Allostasis describes the body's ability to maintain stability or homeostasis through change. And allostatic load describes physiologic dysregulation secondary to exposure to chronic stress. Now, the way that allostatic load is measured is that it's comprised of biomarkers from the stress pathway. So it includes primary mediators like cortisol, which is our major stress hormone. It also includes things that are downstream of cortisol, so secondary outcomes such as systolic blood pressure, and then also includes tertiary outcomes such as hypertension. So what allostatic load allows us to do is to have a quantifiable measure of someone's exposure to stress by measuring variables or biomarkers across the stress response. And the way that allostatic load is conceptualized to work is through a bifactor model where each of the physiologic systems independently contribute to health outcomes, but then they also work together through a common factor, which is allostatic load. So the question you're probably wondering is there really signal for this? Meaning that, is there evidence to show that allostatic load is associated with social determinants of health? And there is. So studies have shown that individuals who experience work-related stress, individuals who have low socioeconomic status, older age adults who face physical and cognitive decline, and individuals who are from historically and intentionally excluded groups like Black women are more likely to have a high allostatic load than individuals who don't have work-related stress, those of high socioeconomic status, older age adults not experiencing physical and cognitive decline, and individuals from groups that have not faced historical and also intentional exclusion. So what about allostatic load in patients who have cancer? Studies have shown that individuals who have a high allostatic load at diagnosis or at baseline have a 24% higher all-cause mortality than those who have a low allostatic load. And that actually every 1 unit increase in allostatic load is associated with a 7 to 9% increase in cancer-specific mortality. Here at OSU, we've done some work looking at allostatic load in both lung cancer patients and also patients with breast cancer. And in our study looking at patients with lung cancer, what we found is what I've alluded to earlier, in that there is an association between social determinants of health, adverse social determinants of health, and high allostatic load. So in this study, this was the Beating Lung Cancer in Ohio cohort, we looked at the relationship between allostatic load and social determinants of health. And what we found were that individuals in this cohort who had a high allostatic load were more likely to have lower educational achievement, report issues with mobility, report issues with self-care, were more likely to have depression, and also had many stressful life events. And stressful life events included things like parental loss or loss of a child, or facing a very traumatic event like a robbery. So these are very highly stressful events. Also, patients who had a high allostatic load were also more likely to have a worse mortality, or had a 43% higher probability of death. When we looked at breast cancer patients, we saw the same thing. So patients who had a high allostatic load are more likely to have multiple comorbidities, and also were more likely to have more aggressive forms of breast cancer. Individuals who had a high allostatic load were more likely to have government insurance, so Medicaid and also Medicare. I didn't put the Medicare data on there because the slide was getting crowded. And also were more likely to report membership in marginalized and minoritized groups, like being Black, and also were more likely to report being single marital status. Similar to the patients with lung cancer, patients with breast cancer who had a high allostatic load had a 46% higher mortality than individuals who had a low allostatic load. And when we broke down allostatic load into quartiles, meaning we broke it up into 4 groups, individuals in the 4th group had a 75% higher mortality than individuals in the 1st group, the 1st group being low allostatic load and the last group being the high allostatic load. So what I hope I've illustrated to you is that allostatic load can be a good biological correlate of exposure to adverse socio-environmental stressors, and also is associated with the worst mortality. So we've just completed the component on physiology, and now we're going to pivot to the molecular implications of exposure to social determinants of health. So there've been a couple of studies trying to understand how, once again, the internalization of social determinants of health have implications on health outcomes. So in this particular study by Zhao and their colleagues, they looked at the impact of allostatic load on the relationship between tumor differentiation and also DNA mitochondrial copy number. So DNA mitochondrial copy number is important because it illustrates mitochondrial dysfunction and has also been implicated in mitochondrial diseases, cancer, and neurodegenerative diseases. And so what this slide illustrates is that studies have shown that individuals who face stressful life events like parental loss or childhood abuse or maltreatment tend to have a higher allostatic load, which results in increased oxidative stress and DNA damage, which is then shown in an increase in DNA mitochondrial copy number. So once again, what this illustrates is that exposure to adverse social environmental stressors not only have implications at the physiologic level, but also can have molecular implications. Another example of the molecular implications of exposure to socio-environmental factors is a conserved transcriptional response to adversity. So the CTRA is a specific gene expression profile among individuals who face certain types of socio-environmental stressors. And what this study by Dr. Cole and his colleagues showed were that individuals who experienced or reported loneliness were more likely to have increased production of this conserved transcriptional response to adversity. And what this response is that there's an increase in pro-inflammatory genes and then a decrease in antibody synthesis and type 1 interferon antiviral response. So the key to this is that individuals who reported loneliness were more likely to have this particular gene expression profile compared to those who did not. And this work has been further confirmed in other studies where individuals who have low socioeconomic status, individuals experiencing caregiver stress, those with bereavement, and also individuals who report loneliness were more likely to have a gene expression profile consistent with having an increase in this conserved transcriptional response to adversity. So what I hope I've been able to illustrate to you through the discussions of allostatic load and then DNA mitochondrial copy number and CTRA is that exposure to social environmental stressors can become internalized, which is the word embodiment, which we used in the ecosocial theory explanation early on, and can have significant implications for disease initiation, disease progression, and also can have implications for mortality. So I've talked to you about a lot of problems, so let's talk about some solutions. So how can we address some of these adverse social determinants of health and their influence on health outcomes? So we did a study here at OSU looking at the implications of Medicaid expansion among patients who were low income, who had breast cancer. And what we found were that individuals we looked at pre-Medicaid expansion versus post-Medicaid expansion. And what we found was that among women who had low income in the post-Medicaid expansion period, they were more likely to get breast conservation therapy. Breast conservation therapy is comprised of breast conservation surgery and radiation treatment. Also, among patients who had mastectomy, they were more likely to get reconstruction. The only sort of thing that did not change is that we did not notice improvements in time to surgery. But the key point of this slide is that well-placed governmental policies can have significant implications for access to healthcare, which can have significant implications for the psychosocial effects of treatment, and also more importantly, can have implications for mortality. Other studies have shown that there are ways to both address the physiologic and the molecular changes from exposure to social determinants of health. And strategies that have been successful include exercise and also psychosocial support. With the psychosocial support, it was a study looking at women who had stage 4 breast cancer. And the study showed that individuals who participated in expressive group therapy actually had a reduction in their allostatic load compared to those who did not. And then with a study on exercise, it showed that women at risk for breast cancer who participated in exercise had also a reduction in their allostatic load. So what these studies suggest is that there are avenues that we can utilize to help reduce allostatic load, meaning that allostatic load and also molecular changes might be actionable. So the key takeaways from this talk are that social determinants of health are powerful drivers of health and clinical outcomes. It is hypothesized that social determinants of health work through the stress pathway. Allostatic load, CTRA, and mitochondrial DNA copy number, I believe, can be operationalized as biological correlates for exposure to adverse social determinants of health or social determinants of health in general, and that we need additional research to better elucidate the pathway between social determinants of health and cancer from etiology all the way through survivorship. Thank you very much for your time, and here are my collaborators here at Ohio State. I'll be happy to answer any questions with the panel session, but if I don't get to your questions, here's my email address. Please feel free to email me, and you can also get in touch with me through Twitter. Thank you very much for your time.
Thank you so much, Dr. Sam. That was so interesting. I was like leaning into my computer listening to you. So thank you for joining us this morning and for sharing your knowledge with us. We really appreciate you. Now we have a really outstanding group for our panel discussion, and our panel is going to be moderated by Christina Austin. Christina, or she also goes by Chris, is a nonprofit leader with strengths in community outreach and engagement, programming, relationship building, marketing, and social media strategy. She joined the Case Comprehensive Cancer Center team as Director of Community Engagement in March 2021. In this role, Chris works with the Cancer Center and its members to drive the Case CCC's efforts in reducing and ultimately eliminating the disproportionate burden of cancer by promoting health equity through systematic community participatory research and engagement. She is responsible for all community outreach and engagement activities within the Case collaboration with center members, the Community Advisory Board, and institutional partners. Prior to joining the Case team, Chris served as Chief Marketing Officer for The Gathering Place from 2003 to 2020, an organization dedicated to the support, education, and empowerment of individuals and families coping with the impact of cancer. She also worked as Hospice Program Manager for Southwest General Health Center, Community Service Director for Community Health Partners, and Bereavement and Volunteer Services Coordinator for Hospice of St. Joseph. She is part of the leadership team for Minority Health Alliance, a community consortium committed to reducing health disparities among minority populations by promoting health, wellness, and awareness through education and advocacy, and serves as co-chair for the Health Equity Committee of Ohio Partners for Cancer Control. Chris is a licensed social worker with a Bachelor of Arts in Psychology from the University of Cincinnati and a Master of Science in Education with a counseling concentration from the University of Dayton. I will now turn it over to Chris, who will introduce our panel and have them introduce themselves.
Good morning, and thank you so much for this opportunity to moderate this amazing panel that we're going to have to continue our discussion on health equity across the cancer care continuum, looking at breast cancer. We are very privileged this morning to have our speakers, Dr. Eleanor M. Walker, Patricia Toussel, Gahada Aziz, and Dr. Somalia Obing-Jesse. I'm going to ask each of our panelists to introduce themselves, give us a brief overview of what work they're currently doing, and then we'll move into our questions. And we encourage everyone that's viewing to please put your questions in the Q&A so that we can present those to our panelists. Dr. Eleanor Walker, we're going to start with you to give a brief introduction.
Good morning, everyone, and thank you again to the American Cancer Society for inviting me to be on this amazing panel, and our speaker that we just had, the amazing work that she is doing in the Ohio area. I am Dr. Eleanor Walker. I am the Director of Breast Radiation Oncology for the Henry Ford Health System. I also am the Medical Director for our Integrative Medicine Services here at Henry Ford. And I lead the DEIJ committee for the Cancer Institute. A lot of the work we've been doing is both with our urban and rural populations, but particularly in the Detroit metro area. We've been doing work with breast cancer patients and prostate cancer patients in educating and partnering with the community, one, to help them to understand the importance of screening and how it affects the Black communities, and talking with their families. Also, we're going out to them and helping them get screened in a place that's comfortable for them, where there's trust. We are also trying to do education in the benefits of participating in cancer clinical trials in particular, because we can't move the research forward if we don't do that kind of work. So thank you, and I'll let my other co-panelists talk.
Dr. Walker, thank you very much for your very impactful work and for joining us this morning. Patricia Toussel.
Good morning. Thank you for the invitation. And let me introduce myself. I work for Metro Health. My position is a bilingual patient navigator and community outreach liaison. So basically my role is, to connect with the community, to provide free mammograms or assistance, for people that need navigation. Like it's very scary when you feel something that is not normal, and you have to navigate that system. So I'm being with Metro for 8 years, and I'm very happy to be part of this group. Thank you.
Thank you, Patricia. Gahada Aziz.
Hello, everyone. I work for Access. Access, it's a community center for the health and human resource services. We serve everyone. We have about like 9 buildings serving everyone, but specifically we have 2 clinics serving the community. I am part of the BCCP. I start working like outreach and navigator for our community. Especially I speak in second language as Arabic. We have a lot of community coming from other countries like immigrant and refugees. They have a lack of education and a lack of they have a barrier of education and language. So we give education in second language. I do a lot of educated from the breast and cervical cancer and colorectal cancer. And we do a free screening for them, the service for the breast and cervical, and we give away to some fit kit and free colonoscopy.
Gahada, thank you so much for being with us this morning.
Thank you.
And Dr. Obing Jesse.
So thank you very much for the opportunity to be here. My name is Samilia Obing Jesse, and I'm a breast surgical oncologist at Ohio State. And I also do health services research with a focus in health equity.
Thank you. Thank you so much, Dr. Obing Jesse, for your very informative presentation this morning. And it's a very important and timely conversation. And as we look at what you shared around social determinants of health and really look at the impact that it brings to disparities in healthcare overall and with cancer care, I think it's very important for us to start this conversation in giving each of you an opportunity to help us look at what is your definition of health equity, since this is our conversation. And Dr. Obing Jesse, I'd love to start with you.
So I'm going to cheat and just use the WHO's definition, in that it's the idea that everybody should be able to reach their full health potential, regardless of their social circumstance.
Mm-hmm.
Would anyone like to add to that?
Well, I just think that is just a nugget that's important that people should keep in mind. I think having the ability to access whatever you need, regardless of where you're from, what language you speak, what your social circumstance is, as Dr. Amaghetti spoke about early, is the most important thing. There should be no barriers.
It's a health equity for regardless of race, ethnicity, disability, sexual and race, language, status.
And also, this is like a continuous effort. It's not something that, like it's a goal, but we have to keep continuing, partnerships, education, doing what we do with the community to get to that point.
Thank you, everyone. And Patricia, I think you said something very important that is continuous. And so that is a significant comment. And as we think about that being a continuous effort, I'd love for you all to be able to speak to what effective strategies you've been working on to increase access to breast cancer care for the population that you serve. And Patricia, we'll go ahead and give you that opportunity to start the answer.
Okay. Here in Metro, like in the breast center, we do try, we have a partnership with BCCP, that is the state program. So, like my first goal to help them is like to connect it to the resources to help them after, get diagnosed or during this process to feel a little release to know that they qualify for BCCP and they gonna be covered by them. Also, like, gotta say, I speak Spanish, so I help with a patient that don't speak English. So I'm helping them, to interpreter, to feel more comfortable during the process. And at the same time, be the support during this time. And also, like we do events in the community that we go where they are. So sometimes these people doesn't want to come to our hospital, but when we go to a church, when we go to an event, we connect with the people and we build that trust. That is what we want to get in order for her to come and get prevention, to keep going with their health and to get the goal to health equity.
Thank you so much. Dr. Walker, can you add to that, please?
Definitely, I agree. One of the very important things that we see are patients are nervous to do anything because of the lack of insurance. And especially in the Detroit area, transportation isn't like New York City, where I grew up, where for a few dollars you can get on a train or a bus that runs 24 hours a day to get your mammogram or to talk to your doctor about changes that you may note in your body. So one of the things that we do is we do have a mobile mammogram that we take out into the community at some of our sites, and actually in community centers, trusted community centers where people tend to congregate, and make it available for patients to get the education and get the screening that they needed. We also work with our trusted community partners to educate the community and partner with the community health workers within our own system and within these churches and community partnerships and nurses to educate and help patients access mammograms for free if they don't have insurance. And then actually, make sure that they have the things that they need taken to them. So I think that's the biggest thing that I see here is getting to the patient themselves, because it's very difficult. I have to say that if I didn't have a car, it would be very difficult to get to appointments in a timely fashion, to get to work in a timely fashion. So just imagine the patients in our community, whether rural or urban, they're facing these challenges also. And that's how we get around some of this in the Detroit area.
Thank you, Dr. Walker. Gahada, what would you like to share with regards to your work at Access?
Yes, see, our community, it's a huge population. And they know we have two centers. See, we serve the two clinics. We serve in Michigan, Macomb, and Oakland and Wayne. Southeast Michigan. So they know these centers, we speak their language. So they came to us for the service. Regardless, they have insurance, Medicaid, mostly they are low income family. So they come to us, we are partnered with the provider. So either if they have insurance or they don't have insurance, the provider, they don't speak the Arabic, so they call us and they translate to their clients if they have a problem or they have issue with the breast, or they want us to explain why they have to do the mammogram, what's the important to do the screening for the mammogram. So we took the clients to the private room. We do like one-to-one education if they are interested for the pap smear too, and we combine the HPV vaccine too for their children. Why it's important to do what the HPV, because they don't have any idea. By the way, we give them the brochures, what the HPV, the sexual activity with their partner. From the pap smear, if they find out was the ascus, where they don't know nothing about the viruses. So we need to explain that to them. We follow up even if they find something abnormal with the pap smear, with the mammogram. We follow up with the clients. We are doing, even we schedule them for the mammogram. They don't know how they schedule the mammogram. They don't know nothing. So they trust us and they call us, they don't call the provider, they call on us because we speak the language, and they ask about the results. Sometimes they don't ask us about, they said, don't call us about the results. They don't know, because the cultures, they scared about the results. Don't call us about the results, but we make them comfortable. We talk about always I put myself, it's example. See, I am a survival. See, I'm okay. I go through, so I make them more comfortable, So this is the way I talk with my community to encourage them to do doing the mammogram every year. So I have always to target, especially with the clients, they don't have any idea about what's the mammogram, what the screening, general and cancer screening.
Thank you. Dr. Obeng-Jesse.
So the Stephanie Spielmann is a very sort of resource-rich facility. And because we're a standalone facility, we have a lot of things in one place. And so we do have social workers, we have patient navigators, and also financial counselors to help patients navigate their cancer journey here at the Spielmann. And all these individuals, including the physicians and nurses, are highly devoted to making sure that our patients are able to access all the things that we have to offer. So we do have very robust systems in place to identify patients who have additional needs. And then we also leverage the resources I talked about earlier to help them address or meet those needs.
Thank you. And you brought up financial navigators and counselors, and I think that's very important. I know I've heard you speak about financial toxicity and its impact on patients. And so I'd love for you and others to be able to speak to what are some of the most effective strategies for reducing the financial burden of breast cancer for patients and their families.
So I think the first step is to actually screen patients for financial hardship. If you don't ask patients if they're having financial hardship, they may not relay that information to you. So the biggest step really is screening. And then once screening strategies are implemented, the next thing is kind of what to do with those results, right? So it's one thing to screen somebody, it's a different thing to have a systematic plan of how you're going to address those findings. So the two key things I would say are screening, but then having in place a systematic plan of how you're going to point or navigate people toward resources. Also, there needs to be more studies looking at the implications of conveying costs to patients. We still are very early in understanding how patients take this information and how they utilize it in their medical decision making. So screening, systematic plan in place, but also a better understanding of what it really means to tell patients the cost and what they do with that information.
Would anyone else like to add to that?
I absolutely agree with that. Again, at Henry Ford Health, we also have financial navigators and social workers, and we have a lot of people working in the background once the community health workers and social workers review the screening information that we've gotten about financial need and work with different insurance companies and try to get patients without interrupting their treatment, because sometimes we find out in the middle, excuse me, of treatment that their insurance that they had is gone. And patients are worried they don't want to come in for treatment. So it's very important that you have this continuous support while working on making sure patients continue to have insurance if they had it to begin with. If they didn't have it, to assure them and find ways to pay for their treatment. And there are many out there. So that's why that financial navigation team and social work is so important, and even the administration. And also philanthropy can help with this, because sometimes it's very simply that they need their car note paid in order for them to be able to come for their treatments each day without affecting their family. For example, yesterday I had a patient who was very late for her appointment, very angry, was difficult with the support staff. And when we finally sat down and talked with her, she had been a caregiver for her husband with lung cancer who died. Now she needed the caregiving, but she had multiple chronic diseases that prevented her from driving and being able to ambulate. So now she's more wheelchair bound, and she's very dependent on her family, who again is like, well, I'm missing a day of work to come and take you to the cancer center, which was what she was reflecting towards us, because she was angry but couldn't say that to her family because it would have impacted her getting her treatment. So by taking the time to sit down with her and asking her about it, we were able to get transportation for her before she left yesterday. And I also asked her at the same time, are there any bills? Do you have need of food? Do you have need for somebody to come to your house to clean your house for you? We can help you with this, but you need to let us know. So communication is so important.
Chris, I want to add something to like everybody's saying, like here in Metro, we have the financial assistance program too. So for the screening, like to see what is the need. And after that, based on the need and what we know about the patient, see what is the source that the patient need to continue their care. Like in the case, like we have patients that they don't have documents, So in that way, like they cannot qualify for Medicaid, they cannot qualify for BCCP. So that is the way that we have this financial assistance program here at Metro, and that we can connect them, and they feel that release, that at least like somebody is here to help them during their treatment. So that is very important.
Yes, in Access, we have in 2 locations, Navigator, we have about 8. We can help our clients for Medicaid or for Marketplace. By the way, I just want to mention something. If any clients from the BCCP, like it doesn't cover like or from Obamacare, some kind of service have like high deductible, or they can afford one of the service like a biopsy, breast biopsy, they can come to the BCCP program. I can enroll them and help the program. They can pay for the service. So this is, can help them. We don't refuse, stop the service, because we need to continue. The clients we need to know what kind of, continue what kind of sales they have. So we don't stop the service for them. So the BCCB, they can pay for it.
Thank you all very much for sharing that information. And the thing that I take away from all of you is just the importance of the screening, connecting with patients, asking them the questions, asking them about their specific needs, because they're not always going to feel comfortable asking for that type of help. So thank you very much. Often when we talk about disparities or looking at health equity, we speak to it from the place of a socioeconomic status, or we look at race and ethnicity. How can we better engage LGBTQ individuals in breast cancer prevention and screening programs to ensure that they receive equitable care? Who would like to speak to that?
I can start, like here at Metro Health, we have a pride clinic. That is so, important that they feel that they have their own clinic, they understand their need, they understand what they face every day, and the social media that increase, the awareness, the importance of prevention. And I even talked with few people that I know that they go to the pride clinic, and they told me, since I come to Metro to this clinic, I feel more that listen better to me, so to make them feel more included in what the clinical thing is the most important thing for them, and this is what we're doing here at Metro Health.
I think here at Henry Ford has always been known in the LGBT community of being a supporter of it. And in various departments, we let people know that we have physicians who specialize in taking care of them. But they have to know, when you're doing education, that you are there for them. You do take into consideration all of the options, because a lot of times I've had transgendered females, and you're trying to discuss the care of their breast cancer, while at the same time I've actually had a few that have had high PSAs. So now we're dealing with two major issues that affects how they view themselves, how they want to live, how they think about it. So you have to have staff available to help support in every way, and talk with them about what is it they want. And sometimes it's not what you recommend, but you still need to help support those patients. And I think getting out in the community also, we have our Pride ERG made up of many people in the health system that goes out in the community and educates and supports the LGBT plus community. So I think those are all things that can help with screenings and why it's important, and know your options before it happens.
Thank you so much. Dr. Obingasi or Gahada, anything that you would like to add to that conversation?
I would just add that one of the most important things is institutional culture. And so making sure that the idea of inclusion for these populations is actually at the forefront of discourse is actually very meaningful, from leadership all the way down to sort of everybody who works in that institution. If institutional culture gives the impression that individuals are not welcome, they're not going to come to your institution. And so I think it's really important that institutional culture conveys that everybody is welcome at the facility.
Thank you for adding that. So let's take a look at what role can technology play in improving breast cancer outcomes and promoting health equity. Dr. Walker, any thoughts on that?
I think COVID helped push forward a lot of the technologies that we were slow in implementing in medicine, particularly video visiting. There are certain things that you could not do virtually, like radiation or surgery. You actually had to have the patient come in. But for the follow-up, everybody has a cell phone pretty much. Even if you don't have a computer, most people have a cell phone. Making sure that there's internet access in the neighborhoods, working with the city of Detroit and the surrounding counties and the school systems to make sure people did have access. And then, you know, giving them kind of decision support tools and education online that they could make decisions, do their follow-ups. There are so many things that you can remotely monitor people with also that allows us to help move everything forward and improve outcomes. And then with our research, if we're working with patients and getting them involved, it takes us forward in our precision medicine plans. For example, here at Henry Ford, we probably have the largest pathology analytics for pancreatic cancer in people of African descent that we can work with because of the patients that we see and talk to them about the benefits to their family down the road. So I think there's a lot that can be done, and the Institute here is very supportive of this. So
please dial
excuse the overhead.
Dr. Walker, thank you for your response. And I think it's important when you talk about also educating people about how to access those technology tools, because not everybody has had that experience. So being able to provide that access, but then also making sure that people know how to utilize what's available to them, and then recognizing that there is also a digital divide within communities, and how do we acknowledge and address that?
Absolutely.
Also, Chris, you know, with social media, you know, everybody's in social media, Facebook, Instagram, Twitter, TikTok. So, you know, like to push education guidelines, you know, like because when I hear a lot in the communities, people is, I don't feel anything, I don't have to do anything, you know, but, you know, like you need to know the guidelines. 40 years old, you need to start getting your annual mammogram, you know, like that is normal, perfect, but, you know, it's something that you should do every year. So pushing that education to social media is something that the technology is helping us to do. But like Dr. Walker said too, you know, like to show them how to use, like we have my chart, you know, like you can communicate with your doctor to my chart, and it's a very helpful tool. So you don't have to come to the clinic to speak to your doctor. You can send a message and the doctor can answer you back. So I think that like COVID it was a very bad thing, but at the same time give us all these options that is helping people with transportation issues, people with, you know, like socioeconomic barriers to get access to a better communication with the physicians and with us.
And actually, if I can add something in terms of technology that's related to my field of radiation oncology, we're always looking at ways to give patients the best treatment in a shorter period of time, because much of radiation takes several weeks to give. But because of COVID, it pushed forth our shortened treatment times, and the research was analyzed and showed that we could give effective, beneficial, durable treatments for patients in shorter periods of time than we probably would have implemented if COVID had not occurred. So that's another way that technology has helped us.
I was going to add, though, that so COVID was helpful in that it helped us advance telehealth and how we interface with patients, but also it had a lot of misinformation, which has been very detrimental to some people. And so I think one of the things that needs to happen is that organizations such as the American Cancer Society, the James, you know, institutions that are reputable need to leverage the social media to get people accurate information so they can make informed decisions. Because of sort of how much information is out there, I think it's difficult for people to discern what is factually correct and meaningful versus what is incorrect. And until organizations really take it upon themselves to help people understand, or at least to decipher what is important, I personally am concerned people are going to make poor choices based on not great information.
That's a wonderful point, actually, Dr. Oben-Jesse, and I appreciate you bringing that up. Is there anything that you're aware of that you are doing with your social media, perhaps at the James or at the medical center to address this around social media, looking at campaigns that help provide that education?
I know that the James Twitter account highlights physicians and some of the work they're doing, so that provides a resource for patients to understand what's going on here. But I don't know of any specific campaigns to combat misinformation on social media.
And here at Henry Ford, we don't have a campaign against misinformation, but we do have social media, particularly, for example, information on prostate cancer screening, that men actually say they prefer to get that information that way, and they respond. That leads them to the Henry Ford page. Women also. So we use our social media a lot because we've asked our community, how do you want to be engaged? How do you want to be contacted? Where do you want to get the information from? And they've asked that we use more social media.
Very interesting. Thank you for sharing that. And I want to, first of all, encourage our listeners, if you have any questions, to please put those in the Q&A, and we'll take as many as possible. I do want to pose a final question before we start to take questions from our audience. A lot of the interventions that each of you have been speaking about are really specific to addressing how you approach the individual patient that is coming in to receive care. So I'm wondering if we can look at this from a more global perspective and consider what role can policymakers play in promoting health equity in breast cancer, prevention, screening, and treatment.
So in my talk, I talked about the Affordable Care Act and its implications for patients in Ohio. And a lot of the data emerging is showing that it's actually been very helpful for patients who have cancer. Patients are being diagnosed earlier, they're getting guideline concordant care, and all these things are going to improve survival from breast cancer. So I think we do currently have an example of a governmental policy that has had positive implications for patients who have cancer.
Excellent.
Also to keep pushing, like state programs, like to keep giving money to support what they're doing, like increasing, like we're talking about BCCP, like thanks to, it's a state program that help us, to provide this release, the financial release for patients that they qualify based on the income, and they will be covered even until treatment. So that is very important.
I think the Affordable Care Act has done wonders. There's room for much more to be done. And I really think that health systems such as Henry Ford and the James need to really work with our state senators, and we engage them. We bring them in and we talk with them, and we actually have them talk to patients too when they come into the cancer center and into the main hospital, because they really, health systems can really push our state government to implement these policies and to make changes. And also being part of, for example, the governor's task force on how we improve care for patients across the state is very important, to be active in our state medical groups and in our state government. That is going to move the needle.
Thank you all very much. Gahada, was there anything that you wanted to add to that before we take questions from the audience?
Yes, that's we agree with the groups. It's more research, more fund, more support against the breast cancer, and support all the community. Regard race, regard language, as I mentioned, and really I support everyone. Thank you for this opportunity.
Thank you. Dr. Obeng-Jesse, we have a question for you regarding your study that you shared. And the question is, did you see any impact with use of patient navigators and or social workers to address social determinants of health with patients?
So that study was a retrospective study. It wasn't a prospective study. So we did not look at social work or patient navigation as interventions. So unfortunately, no, we did not have that information for that particular cohort.
Thank you. Does family history of autoimmune conditions predispose women to breast cancer?
So the data on that, for some types of autoimmune diseases, there appear to be an association with a lower risk. So for example, rheumatoid arthritis has been shown to have a lower risk. And then some like psoriasis have been shown to have a higher risk, but the data on that is still emerging.
Thank you. Gahada, this question is for you. I studied disparities in breast cancer characteristics among Syrian refugees. Can you please share what culturally tailored or translated breast cancer resources are available to help navigate refugees from detection to treatment?
Yes, we have a lot of refugees really from Syria. Not just from Syria, actually. We have a lot of still coming. I'm starting like from zero. I start to educate this kind of community, okay, from zero. And we have a lot of resources for them and educate them, enroll them with this programs, BCCP. I go for, they have a small community, go for their home visits. I go for, they have like a mosque, they have their own mosque, do a lot of education, enroll them with either with the, if they have Medicaid or they have like a marketplace. I go with them and really or they have a BCCP. I go enroll them. I go with them really. Even I volunteer for transportation. Go for screen mammogram. You know. So yeah, I always with them. They know me as a community. You know, part of the community. And yes, you know.
Thank you. Dr. Obing-Jesse, this is for you. Have you considered the data indicating the biological differences in Black and white cancer cells and genetic differences in triple negative breast cancer in women? It seems that the current therapies are not effectively treating Black women.
So we actually have two studies that are going to address that. We have one that's funded by the American Cancer Society. That's going to open up soon. It's a study looking at tumor genomic profiles in Black and white women, and also looking at the tumor microenvironment. And it's trying to understand how allostatic loads, so biological correlates of stress, may be associated with racial differences in tumor gene expression profiles and also the tumor microenvironment. We have another study that is currently enrolling here at OSU and also Indiana University that is looking at the relationship between genetic ancestry and also treatment tolerability. So treatment response and actually being able to complete chemotherapy. And that study is funded by the American Society of Clinical Oncologists. So yes, we are aware of those issues, and we've been lucky enough to receive some funding. And hopefully within the next couple of years, we'll have some definitive results that can help improve outcomes for women of African ancestry.
Wonderful.
And here at Henry Ford, we have a researcher, clinician scientist who does a lot of work in triple negative breast cancer. She actually, we go to Africa and bring back tissue so that we can actually study and look at radiation and chemotherapy and organoids that are created, so we can look at these differences and find ways to improve treatment of triple negative breast cancer, which tends to affect, as we know, women of African ancestry more. And you need to be able to look at these things in order to take the next steps in creating drugs and treatments that will be more beneficial. Because as we know, a lot of the improvements in breast cancer care occurred in HER2 positive or triple positive, ER positive tumors, and really didn't address women of African ancestry. And because of fear of what was done in the past in many different areas, I mean, everybody talks about Tuskegee and Henrietta now, but there were things done putting active uranium in people in the past to see what the natural history was. So obviously, different communities are afraid of participating, but we hurt ourselves if we don't educate ourselves about the benefits. We have to have a population of people that we can actually look at responses. I mean, I'm old enough to know when they realized that not having enough women on colorectal cancer trials gave us the wrong outcome for women versus men. So, you know, we need to talk to the community about that and educate them. That's what they ask us for in Detroit. Educate us first about clinical trials before you ask us to participate in a cancer clinical trial. And that's some of the work that we try to do here. And, you know, using alternative treatments, well, we all have to educate ourselves. I'm part of Society of Integrative Oncology. I've done a lot of research in integrative oncology. So I sit down and talk with my patients. It's part of the history I take. So if you're taking something, I can sit down and have a discussion with you why you should or shouldn't, or when during your treatment it would be most beneficial. And encouraging the exercise, like Dr. Open-Jesse talked about, very important in all our communities. But you have to be able to sit down and discuss it with a patient, and then they're more likely to think about it and consider it.
Thank you, Dr. Walker. Actually, there were a couple of questions in the chat with regards to clinical trials, and one specifically asking what you were doing to get more Black women into clinical trials. And I think overall, as we look at, you know, how do we ensure that research on breast cancer and other research is inclusive, particularly of underrepresented populations. So I think you spoke to the importance of educating the community. And this question goes to anyone. Is there anything that we need to be doing within our systems with regards to how we talk to people about clinical trials? So if anybody would like to respond to that before we close.
Well, I think many systems, including ours, have, and it's become a requirement for the state of Michigan anyway, for physicians and various providers. But part of what we develop very specific for our Cancer Institute is implicit bias training, because sometimes we have to be aware of how we speak to people and how it comes across. We may say something that we think is not offensive, but it may come across offensive. How we approach a person to participate in a trial, well, if they don't understand the importance of the trials and you just don't take in the cultural barriers that may prevent them from participating in trial, or how culturally they need to be approached. Have you spoken to their trusted community partner, especially in the Arab American community? I would say I've learned a lot about the Arab American community here, and how I'm going to approach a person in the Arab American community may be a little bit different than how I would in the Black community or even the Hispanic community, just because I'm trying to be culturally sensitive. And I think if we all realize we have some biases and we always need to be cognizant of how we talk to people and how we ask them to participate in trials, then we'll do better.
Thank you for that. Anyone else? Patricia.
Yes, please. Also, you know, like to incorporate more diverse clinical team, you know, like what we're doing here in Metro, we have even clinical coordinators and nurses that they represent minorities. So they will feel the patient more comfortable when somebody approaches them that they look like them, to tell them, this is what we're gonna do. I'm gonna be holding your hand. I'm gonna explain everything that is gonna happen in this trial. So you're good. So basically giving that peace of mind that what you're doing to me, you know. So this is what I think that is important, to have these minorities represented in our clinical team too.
Thank you. I just want to let our audience know there were a few more questions that are in the chat. We will make every effort to follow up with our speakers so that they can provide answers to those questions and get those back to you, because we are coming to a close for our panel. I would like to thank Patricia Toussel, Dr. Eleanor Walker, Dr. Samilia Obenjesi, and Gahada Aziz very much for this opportunity to have this important discussion with you. Thank you to the American Cancer Society and to the James for making this opportunity possible.
Okay, thank you so much, Christina, for hosting such a fabulous panel, and thank you for our panel members for a great discussion. We're going to pop up another poll question before we move to our first case study presentation. Give that a second to pop up.
Megan, I'm afraid when I lost my Zoom, it knocked out the poll question. So I think we should move forward.
Okay, we will move forward. So our next speaker is Beth Seeloff. Beth received her undergraduate degree from Spring Arbor University and her graduate degree from Grand Valley State University. She's also a graduate of the Key Executive Leadership Program at American University in Washington, D.C. She has additional certifications as a yoga teacher and a children's yoga teacher. Beth is a member of the Rogel Center Cancer Center's Community Advisory Board, the Michigan Oncology Quality Council, the Michigan Cancer Consortium, and serves on the George Washington Cancer Center Comprehensive Cancer Control Technical Assistance and Training Steering Committee. Beth Seeloff is a 27-year veteran of the United States Air Force and retired at the rank of Chief Master Sergeant. Beth has been a healthcare professional and leader of national programs for more than 30 years, and a leader for the tribal health programs at the Intertribal Council of Michigan since 2018. In her current role, she administers and implements public health programs for federal, state, and tribal organizations that ensures health equity for minority and priority populations and the sovereign rights of tribal organizations. The scope of her work supports cancer prevention and cancer intervention activities for tribal communities and the Native American populations across the 61 county service areas in the state of Michigan. Beth is dedicated to ensuring Native Americans have the most accessible and evidence-based screening and treatments for prevention and disease. She has collaborated with state and national organizations to eliminate barriers to cancer screening and has developed culturally appropriate and effective education materials and curriculums for American Indian populations. Beth has managed the BCCCP for the Intertribal Council of Michigan since 2018 and was awarded the Michigan Cancer Consortium Spirit of Collaboration Award in 2019 for her work with Betty Ford Breast Services and the UP Tribal Health Centers. Dedicated to eliminating barriers to cancer screening, in 2021, Beth successfully changed the Michigan Medicaid policy from a limit of 1 screening mammogram annually to 1 screening mammogram per year with no annual limits. I'm going to turn it over to Beth to present her case study for us. And Beth, you can just let us know when to advance your slides.
Okay, thank you. Good morning, everyone. I'd like to just give you a little bit of information about the Intertribal Council of Michigan. We are a nonprofit organization, and we serve as a forum for the 12 federally recognized tribes in the state of Michigan. And we are dedicated to advocates for reducing chronic disease, cancer disparities, and our programs specifically support culturally appropriate education, training, policy, and capacity building to support health equity among our Michigan tribal communities. Next slide. I want to tell you a little history about behind the why and why I'm here today specifically, and why the Intertribal Council exists, and how important equity and opportunity for wellness is important in our Native American communities. As recent as 2021, Dr. Perrett from ASCO specifically stated, although we have seen steady declines in cancer mortality over the last 2 decades, for American Indians, the rates keep increasing. Native Americans are the most underserved minority populations in the United States, and as just recent research really shows, disproportionately affected by cancer. As you can see, they tend to undergo less likely to undergo diagnostic cancer screening, and these factors the reason for that are health literacy, access to care due to structural barriers, and locations of reservations, and the trust in the medical system. And this is a little unknown fact that as recently as 1976, American Indian women had been involuntarily sterilized. So they would go in for a tonsillectomy at the age of 10 and would have a tubal ligation. They would go in for, as an adult, they might, or as a young adult, right, go in for an appendectomy, and they would have an ovarectomy. So this has gone on for years, right? And it went on prior to 1973, and it went on a little bit beyond 1976. So the trust factor and that trust in the medical system, it was a big factor in these cancer mortality rates and cancer incident rates. And the reason, most important reason behind the why is Native American women, like all women living in the rural and austere areas of Michigan, are entitled to equitable access to high quality care. And I'm here today to talk to you about the successes we've had in our collaborations and partnerships and building trust. Next slide. So as an organization, right, I reached out to anyone who owned a mobile MAM unit in 2018. And I told them our story, and I told them the areas where we serve women across the state of Michigan. And Betty Ford Breast Care Services opened up their organization to support us. On the map here, you'll see the state of Michigan is quite large, and Grand Rapids is located in Southwest Michigan. And our tribal organization, our tribal communities in the Upper Peninsula of Michigan, one is Bay Mills Indian Community, which is right on the border of Canada, right on Lake Superior. If you move to your left, you will see that over near Escanaba is the Hannahville Indian Community. And as you go north, you will see the areas of the Keweenaw Bay Indian Community and the Lockview Desert Indian Community. And I show that dotted line because Lockview Desert actually will transport their women, right, via bus up to Keweenaw Bay. And this is the first year we're doing this, and we're really excited about expanding the service area. So next slide. So on this slide, I want to highlight some of the qualitative remarks, like they mentioned how we changed the Michigan Medicaid policy, and the importance of that is no annual limits on screening mammograms. And what we discovered in 2019 and 2020 is women who were on Medicaid recipients and beneficiaries, if they received their mammogram on September 20th in 2019, they couldn't get their screening mammogram until September 22nd in 2020. So if the mammogram ban came a week earlier, then we excluded a number of women from getting their screening mammogram. So these are policies that you should look at, right? Identifying the barriers that health systems have entrenched in their policy, like these Medicaid policy laws, and they're not the same for every state. So I encourage you to look at your Medicaid screening policies to ensure that there are no annual limits on screening mammograms, right? So that if the opportunity for screening comes up, maybe 30 days sooner than they did the year before, that they have the opportunity to be screened. We did a lot of work on increasing and educating providers and health systems on mandating clinical breast exams. We found in some of the rural communities in the Upper Peninsula that women were prevented from getting getting a screening mammogram until they had seen a provider and had a clinical breast exam. And there is no requirement. It has just been a policy that was established years ago during the by the insurance system. That policy by the insurance systems has changed. The science has changed, but the education wasn't there. So that was a big effort. And then most importantly is creating a trusted setting that supports healthy behaviors. And the proof that this is an effective strategy that we're taking here is that our exit interviews, 51% of the women said they would not have been screened had that ban not been in place. So this collaboration of health systems, the tribal health systems, the collaboration with the tribal health systems and Betty Ford Breast Services has been very important in building this trust and improving health literacy in our rural tribal communities. Next slide, please. And when we improve equity and equitable opportunities for screening, and we build that trust, we see an increased demand for screening. And despite the pandemic, right? So we screened in 2019 and 2020, our event was in September. And we proceeded on. That van drove across the Mackinac Bridge and made its way to our first tribal health center in at the Bay Mills Indian community. And we increased our screening to 118 women. In 2021, we were still under the operational requirements of the pandemic, and we increased screening to 135 women. And in 2022, we increased screening to 148 women. And this all took place in 5 days. So we attribute these increases in screenings to trust, right? Women come back and they're like, I'm so glad you're back. Do you remember me, right? So we are building this trust among the women, and they trust these providers that drive up from Grand Rapids, right? They never met them before 2019, and now they know them by name. And our screening rates in these specific tribal communities, 78% of the women with the current mammogram completed their screening at the mobile mammography event in their community. And throughout the pandemic, right, in September 2020, and we asked this question again in 2021, the women said, 96% of the women said they felt safe getting their mammogram, and they were pleased that we showed up in areas where they were told, don't come to the hospital, don't get unnecessary, we're going to postpone your screening, right? We showed up and we were there for them, and that continued to build that trust. Next slide, please. So when we build trust, right, we sustain equitable opportunities for cancer prevention, early diagnosis. And the reason for these sustained equitable opportunities is funding. So Corewell Health volunteers, their staff to come up, they pay their staff their hourly wages, and we pay for any administrative fees and fuel. It's not a big cost, but all of that is possible through the BC3MP program. It's deliberate planning. We have a planning committee that starts meeting in March. We will set our dates for 2024 in October of 2023 so that we know where we're going in the following year. We utilize multi-component interventions, and I foot stomp the EBIs every opportunity I have. The elimination of financial and structural barriers, as has been echoed on this entire call, is the reason that we have increased the screening rates at some of our tribal health centers from 44 to 72%. The patient navigation for this event has showed our tribal health centers how important patient navigation is. So when the mobile MAM unit is not in town, the tribes have been using navigation strategies, and women who previously were not participating in getting their screening mammograms have done so even when the mammogram ban is not in place. And of course, mass media and social media is really important in our rural communities, whether they're rural tribal communities or just rural areas in general, because folks in rural areas don't always have access to Wi-Fi. They don't have computers, and access to the internet via Wi-Fi is just not possible when the Wi-Fi connection's not there. So it's word of mouth, mass media, and when folks who do have in our tribal communities are very connected via social media. So that's how important that is. And most importantly is the compassion and dedicated staff. I cannot say enough about Betty Ford Breast Services, and I'm sure that the staff in our tribal health centers would echo that. They are here, they're compassionate, a lot of our women have endured years of trauma, mistrust, and they meet them where they're at, and that is most important, more important than anything else. And my favorite response when we asked, how was your experience today, shows that the efforts that Betty Ford Breast Services, our tribal health centers, and all the staff that support this event are doing the right thing in the right way, is because this response states, my experience was comfortable. It's nice to know what's going on with my health, and especially doing it right here on the reservation. We want to sustain this program. Like I said, we're going up on September 18th. So if you're in the UP and want to stop by, send me an email and I'll tell you where we're at. Next slide, please. I want to share this video. This is the voice of staff, community members, and cancer patients in the Hannahville Indian community. And when we talk about cultural humility and implicit bias, I want to also mention cultural intelligence. And I want you all to listen to these voices and put yourself in the seat of the patient. Some of these patients, when they're diagnosed with cancer, are traveling from the Wisconsin border all the way down to Henry Ford Hospital, Rogel Cancer Center, Carmanos Cancer Center. They're not always being treated in their local community. So because the capacity is not there in the UP, they're forced to travel further. So it's important, and I hope you will listen to get a better understanding based on the words from the folks themselves. Thank you for allowing me to share this with you today.
Give us 1 second as we pull the video up. And thank you, Beth, for sharing.
This is such an underserved population that there is so many barriers that we see out here that you wouldn't typically see in a different setting. We're having a hard time getting people to their appointments, having reliable transportation, people knowing what is being explained to them at their appointments. They are coming back from meeting with their oncologist and being so confused and not remembering what the plan is or what kind of medication they're being on.
You know, we've unfortunately had some experiences during those last couple of years where people, it's just taken them so long to get in, and then sometimes it's been a little too late and past the point of treatment.
I think that the support system in a community, and especially in a rural indigenous community, is like vital for our survival.
I found the lump right at the beginning of the pandemic, and I had to go to every single doctor appointment, every consultation, and everything all by myself. I wasn't allowed to bring anybody with, and it was very hard. I only got to bring my brother with the day I had my double mastectomy. It was kind of hard because when I got home, they were asking me, what did they say? What's going to happen? I'm like, I don't know. I don't remember. I'm just sitting there and I'm like, I got cancer, and they're throwing all these different long names at me, and I was just I said, well, I'm just going to do chemo, I guess. And then I have to have surgery, and then we'll go from there.
I have talked to people that have told me I'm going to miss my last 3 treatments because I have to pay my bills and I have to go to work. So I can't go to treatment because I need to be at work. Otherwise, my lights are going to be shut off. And having that decision to make, whether they're going to take care of themselves, their life, to save their life, or to provide electricity and food, those are all things that some people, myself included, never had to think about or stress about, and that's not the case for others, especially for here on the reservation in Hannahville.
I don't like to ask for help. I'm not a person that will ask for help. I will not ask unless I really, really have to. But when it comes to checking for breast cancer, yes, it is very, very important to ask for help. I thought I was just reaching out to the nurse and stuff, and then I had learned about the cancer outreach program, and then I just start going right through her, and then it was pretty easy just going through her for everything instead of having to go with one person and another person and another person.
So for somebody that's a consultant like yourself, it's going to be difficult to get that trust sometimes from our Native American patients, and not just the patient, but their family too. They're going to sometimes be on edge, or they're going to be even quiet and reserved in their demeanor, and they may not ask a lot of questions, but that doesn't mean that they're not interested in their own health too.
It doesn't take much to just pick up the phone and ask what you can do or how they're doing for your patient, and just making sure too that you're connecting them with those local resources in their own community where they feel comfortable, and then so they can meet with the traditional healer, they can meet with behavioral health, they can meet with food commodities, anything that you can do to help that person get through this journey in any capacity, even if it's not just seeing them face to face for a doctor's appointment, is wonderful.
I'm using my medicines all day for smudging and prayer, and I need them. I carry them around. I have all the medicines right now with me, and it is an definitely important piece to healthcare, health, healing, mental health.
Our hopes are to grow a community that it's ingrained to have preventative screenings done yearly, and that they make their health a priority. So then that is how they grow up, and they know that because they were modeled that from their elders.
All right. Such a great video. I've seen it a few times and I still love it every time. So thank you, Beth, for sharing. We are running a little bit behind on time, so I hope everybody can stick with us because we have another case study that is just fantastic. We've heard a lot about BCCCP today from our panelists and our speakers. So I'm inviting Kristen Preble and Beth Hollander from the Michigan BCCCP to talk a little bit about the work that they've done here in Michigan.
Great, thank you so much. Good morning, everyone. My name is Bethany Hollander, and I'm a program consultant with the Michigan Department of Health and Human Services Breast and Cervical Cancer Control Navigation Program. So my colleague, Kristen Preble, and myself are very honored to be here today. This has been just incredible. And we'll be sharing some case examples of the work we do to increase breast cancer screening across Michigan. Next slide. So a little bit about our program. Since 1991, the Michigan Breast and Cervical Cancer Control Navigation Program has provided low-income, uninsured, and underinsured individuals access to breast and cervical cancer screening services. So the goal of our program is to make sure that all Michiganders have access to timely and life-saving breast and cervical cancer screening, regardless of insurance status or ability to pay. And we focus on populations that are less likely to be screened and that experience higher rates of breast and cervical cancer morbidity, mortality, and late-stage diagnosis. Next slide. So to accomplish this, we work with a network of valued partners, some of which you've heard from today, and include health departments, health systems, FQHCs, tribal clinics, national, state, and community-based organizations to first identify and enroll women, and two, to support the implementation of evidence-based interventions at the clinic level to increase screening rates, but also enrollments. Next slide. So to start off, I'd like to share some results of a formative evaluation our program did at the beginning of the grant cycle. Last fall, we conducted semi-structured interviews with staff from 8 local coordinating agencies or health departments. And the purpose of the study was to capture the potential implications of budget cuts at the national level, but also to learn valuable insights from our partners surrounding program implementation, and to identify specific actions that we can take to support program implementation. Next slide. So in terms of overall barriers reported to us by the health department staff, 3 major themes emerged. First, limitations with health department staff resources was common. Our participants reported reduced staffing and resources and decreases in their capacity for community outreach and participant identification. Also, there was decreased capacity for provider outreach and recruitment, which means fewer contracted providers to do the services, and decreased funds for local program advertising. System barriers included lack of access to primary care providers, especially in the rural settings, a limited number of providers to perform CULPs, limited scheduling options, which really places the strain on the patients and the participants not able to take time off work or from caregiving, and then also transportation barriers. So in terms of health equity, participants identified lack of language interpretation at the time of the appointment. Also, radiology sites having more stringent rules to assure payment, leading to, yet again, clients being turned away if there's a perception that payment is not guaranteed. And lastly, a participant identified difficulty ensuring Hispanic and Burmese populations access and said they're seeing these populations turned away from service if payment cannot be confirmed immediately. Next slide. So as we drill down further to understand barriers experienced at the point of linkage to the MAM facility, 5 additional themes emerged. So in regard to billing, some program participants received a bill despite being enrolled in the program. There was also missed opportunities for program enrollment. For example, women who are uninsured or getting turned away and who face a high deductible. Miscommunication is also a problem, resulting in, as I described, bills being sent, loss to follow-up, lack of language translation support. In terms of program barriers, participants identified lack of knowledge of the program at the provider level, and know that some facilities require an added and unnecessary voucher to assure payment for service, thus creating another barrier. Lastly, participants described health equity barriers, including stigma for uninsured individuals, discrimination in the healthcare system, and patient discomfort with the facility. So these barriers are, painting a picture of the hurdles an individual can face, especially low income or vulnerable individual, what they must overcome to receive an existing service. And with that, I'm going to turn it over to Kristen, who will share examples of community outreach we're doing to better reach and support individuals in their breast cancer screening journey. Thank you.
Thank you, Bethany. So I will be reviewing how we use that data that Bethany went over towards community outreach to help women learn about and access our programs. Next slide. So the Women's Health Partnership Campaign was created in fall of 2022 and is designed to help Michigan women enroll in BC3NP along with WISE women to access their screening services, engage women, and help women access health services within their own communities. The campaign was created to help decrease the public mistrust of government resources by collaborating with other organizations that are trusted by the communities that they serve. Next slide. So this is a list on our campaign website of some of our partners. Not all of them are listed on this slide, but this is to highlight the mixture of government, nonprofit, and private entities, many of whom have talked today, that we have networked with. Many of these that are listed are actually from the public library system. Next slide. So the campaign has grown within its first year. This map shows our largest partner groups and how the connections were formed, all stemmed from initial connections we had through MDHHS, WISE Women, and/or BC3NP. Over time, our partners connected us with their own partners that they believed would benefit working with us. In some instances, there are more than one connection to a partner, such as MyBridges and a religious nonprofit called Strangers No Longer. Partnerships are designed to be flexible, so we listen to what the partner organization desires, what needs their communities they serve have, and how the information would best be spread within their community, which we'll get into as I discuss the 3 cases. Next slide. So for case number 1, this is the Michigan Library System, and they are our largest initial partner we first started with. We learned through focus groups that libraries are a trusted resource for accessing information such as social services, resources, local events, and also utilizing internet. Libraries also offer, like I mentioned, offer internet sources, and they have been found to be utilized by households that do not have Wi-Fi. So what did this campaign look like with the libraries? The campaign team presented a webinar for all Michigan librarians and library staff about both programs, the services it offers, and how librarians can help women access these programs online, use MyBridges, which is another partner I'll go into later. And additionally, we created bookmarks that were shipped out to libraries recently for visitors to take. Next slide. So these are the bookmarks that we sent out. They're double-sided. One side goes over BC3NP program, and the other side will go over Wise Women. We also added in a QR code to their respective websites to make it easier for women to access information. Next slide. So our second case is the faith-based outreach that focus groups also stated that churches and other religious-based locations were a commonly used resource that participants use to access information, again, about local events, resources that may benefit them. So the plan for this one, we created a faith-based flyer with program information that can be utilized at a variety of religious centers who partner with us. And through the collaboration with the MDHHS Office of Community and Faith, we were able to connect with specific faith-based and religious communities throughout the Detroit area that we were later invited to attend their religious services on Sundays and other religious events to share information in person with their congregation and religious community. Additionally, this is new, but we are in the beginning stages of discussing coordinating what a mammography van would look like to be located at some Detroit-based churches to help women better access screening services. Next slide. So for the last one, this is case 3, going over MyBridges. MyBridges is an online application to apply for and connect with state assistant programs within Michigan. Navigators help Michigan residents access and apply for programs to meet their needs as self-reported. So the plan for this partnership has been less involved for the campaign compared to the libraries and the faith-based organization. And this is because BC3NP is offered through MyBridges, and it's automatically navigated to women who are not eligible or who are denied Medicaid. Additionally, to connect between our partners, librarians were taught what MyBridges is and how they may be an assistance to women who are coming in to utilize library internet to access MyBridge websites. Librarians, I want to make a note, they're not functioning as a navigator, just as a resource to help them utilize the internet service. Next slide. So overall, there is an importance of utilizing networks and partnerships to share resources and starting with the networks you do have currently. Using existing data structures and listening stakeholders is also important, along with getting out in the community for face-to-face interaction. Finding and partnering with resources trusted by the communities to overcome mistrust, commonly associated with state and government programs. All of these have been found to be important for us as we have grown out our network to help women access these services. And many of these women who could benefit from BC3NP. Thank you.
Thank you both so much for sharing. Really great work that you all are doing to get the word out about BCCCP. I think that Gada had touched on that earlier, that so many people just don't even know about it. So really appreciate all the work that you all are doing. Before we close, I just want to make a note that October is coming up and the American Cancer Society will be hosting plenty of events in your communities related to raising funds for breast cancer. And without raising those funds, we wouldn't be able to do research. Dr. Obenjesi mentioned, ACS funded research. We wouldn't be able to fund that without the funds that we raise, or be able to do screening and prevention projects like one we have with Henry Ford right now to increase screening rates with breast cancer. So feel free to take a look at our website, see if there's a breast cancer walk near you that you want to join and come out. We would love to see you there. I want to remind everybody as well that our next virtual forum is going to be on November 2nd, and it's going to focus on health equity in lung cancer. There's a QR code right here that will take you to the registration page if you are not already registered. And I also want to remind everybody that the CME certificate will be sent out in 2 weeks. Once you've completed the post-event survey, the survey will pop up at the close of today's session, and you'll also receive a post-event email with the recording of the session and the survey link in case you missed it this morning. Thank you again so much for joining us today, for all of our speakers and our panelists, and thank you for the commitment to fight for a world without cancer.